Okay, well, it looks like we've got a group here together of at least 17 or so folks. Some other people, some stragglers might sign on, but we'll go ahead and get started. So for those of you that don't know me, I'm Kirsten Alland. I'm a psychiatrist, and I run the UW Boise Psychiatry Residency Program. And our chief resident set up grand rounds, and last year, our chief residents booked Dr. Toor way in advance to get her on our schedule this year. So we're really appreciative for her joining us. She's from the University of Washington and here to present our grand rounds today. Dr. Toor completed her medical school training at Russian State Medical University in Moscow, Russia, and then completed her psychiatry residency program at Tufts University School of Medicine. She also completed a psychosomatic fellowship through Harvard and Cambridge, Massachusetts. She is an assistant professor at the Department of Psychiatry and Behavioral Sciences at the University of Washington, currently leads the integrated care pathway for the psychiatry residents that are in Seattle. And she's the medical director of the Integrated Care Fellowship at the UW, and also works as an inpatient attending psychiatrist at the UW Medical Center. So she's here today to discuss perinatal schizophrenia and postpartum psychosis with us. So thank you, Dr. Toor, for coming. We really appreciate it.
Thank you, Dr. Allen. Thank you for the nice introduction. Just to add, I did my med school in Russia, but then I did take my exams in India and did practice there before I came to US. So I have a little bit of exposure to different countries. But I've decided to settle here and do psychiatry. So it's a pleasure to be here. And perinatal psychiatry has been one of my interests since my second year of residency, when I had my first psychotic patient and inpatient. And we all were trying to figure out how to treat that patient. That's when I really got interested in perinatal psychiatry. And after that, I got a lot of experience, and I worked in UMass with Dr. Nancy Byatt, where I learned a lot about perinatal psychiatry. And here in UW, University of Washington, I am one of the psychiatric consultants for Palform Online, which is a consultation line. So this has been my interest for a long time, and my favorite part is things keep changing and people are interested to learn more about it. And it keeps us on our toes because literature and data keeps changing in perinatal psychiatry. So today's topic, perinatal psychosis. My goals or learning objectives from this presentation, I'm hoping by the end of it, you understand the impact of psychosis in pregnancy and postpartum, understand key components of management of psychotic symptoms, and describe symptoms for postpartum psychosis specifically, and also understand, at least have a broad understanding about risks and benefits of antipsychotic use. Kristen, is it okay to wait to answer any chat questions, or is it preferred to check during presentation?
It's your preference. I can kind of watch the chat if you want, and if something comes through, I could let you know. And then people tend to also just kind of pipe in with questions if they have some too, if that's okay with you.
Okay, yes, sure. I'm hoping to have some time in the end, but please do interrupt if it's relevant questions to what we're talking about. So starting with psychotic symptoms. So this is a psychiatry department. My understanding, most of the people in this are psychiatry background. So I don't need to spend too much time on this, but only thing I want to emphasize is in psychotic symptoms, what I'll talk about first is more of schizophrenia or chronic psychotic disorders instead of other presentations which can present with psychotic symptoms. So schizophrenia or chronic psychotic, primary psychotic disorder. So peak age of onset is during childbearing age. So makes it more important to learn about how to manage this disorder during pregnancy. Traditionally, it was thought that fertility rate in people who have primary psychotic disorder, schizophrenia, are low. But in 2009 study, it was pretty comparable to unaffected population. The rates have actually increased from that traditional years ago. And one of the hypotheses is thought to be the use of more of atypical antipsychotics, which have comparatively less sexual side effects. Another key thing to keep in mind, pregnancy is not protective against acute or chronic psychosis. Even I remember hearing in my first year residency that it can be protective for some mental health disorders, but it's usually not. relapse can happen if the patients are untreated. And my patient, which I had first time in my second year when I was doing inpatient psychiatry, actually did stop all her antipsychotics. She was very disorganized, but she had that in mind that medications will be harmful for her baby, so she stopped them. So she actually spent most of her pregnancy inpatient because she was so disorganized and not cooperative with the medications. So factors to think about in primary psychotic disorder patients: they are at a higher risk of sexual assault, coerced sex, and my patient actually had that, and that's why she got pregnant. Higher risk behavior, substance use, poor nutrition, social risk factors to keep in mind: homelessness, a higher risk of intimate partner violence, limited social support, high rate of repeat rapid pregnancy. And when I say rapid pregnancy, it's within a year of the delivery. Higher rates of unplanned and unwanted pregnancy. So I do want to mention that I say higher rates. I don't mean all of them. None of these patients want to get pregnant. There are patients who actually function better because of being mother. But the studies have shown higher rates of unplanned and unwanted pregnancy. The reason for me to add this slide and to kind of stop and think about these factors is because pregnancy in general is complicated and very a lot of changes for women to go through. For patients who are already having significant psychotic symptoms or a diagnosis for which they need extra support, pregnancy is a time that they will need more of a team approach, or at least think about the factors which can impact their pregnancy period or postpartum. Pregnancy risks: their patients with psychotic disorder are increased risk of C-section, premature rupture of membranes, placental abruption, inability to recognize labor. My patient had a hard time cooperating. The patient I talked about at second year, because I think she's my patient. I always think about my first patient from whom I learned a lot. For her also, she had very hard time recognizing she's pregnant, and also cooperating with the OBs to get examination done. So again, other risks: induction of labor, longer hospital stay. Less than 50% actually end up needing hospitalization. Fetal risk, fetal distress, stillbirth, congenital malformations. There is a higher risk with patients who have chronic psychotic disorders. There was this review paper which came in 2019, which looked up all studies from, I think, 1982 to see what are the impact of schizophrenia on pregnancy, neonatal, infant, and offspring neurodevelopment outcomes. So one thing was noted more was this congenital malformations in the baby. So to summarize that paper, in pregnancy, it was noted higher risk of gestational hypertension, pregnancy, birth complication. Another paper in 2019 showed twofold increased risk of gestational diabetes. Fetal change affects congenital malformation. That was seen in more studies, 6 studies. Unexplained perinatal death of offsprings, fetal deaths from severe neurological malformations, and neurodevelopment. There were less studies on that, but whatever the studies which were there, they showed likely to have intellectual disability and developmental delay. Having said this was a good review paper, but it had a lot of limitations because a lot of these studies could not control like which patients were on medications. Some patients were using substance use. So there's limited data generally in perinatal psychiatry, but even in that, there were a lot of limitations in this study. So it was unclear whether these effects were just from psychotic disorder or the other factors. Postpartum risk for schizophrenic or chronic psychotic patients, risk of symptoms can exacerbate up to 12 months. So if you have a patient who was stable, delivered, it's making sure to keep monitoring for at least 12 months. And of course, the regular protocol after that, how you manage your psychotic patient. Frequent monitoring is recommended because it's hard time for them to bond, to figure out this new responsibility when they themselves are struggling so much. Difficulty bonding, poor infant care, risk of suicide and infanticide is high, difficulty caring for babies, especially at night. So I talked about different factors to keep in mind in pregnancy for patients who have severe mental illness or chronic psychotic disorders. So how do we approach this? So some points to think about when you have a young patient who has diagnosis of schizophrenia or patient in childbearing age. So ideally, it would be great to discuss desire to get pregnant. And if patients are not interested, discussing about contraception or working with the primary care or OB to discuss that with the patient. Planning, if patients are interested, then planning for motherhood. And what does that mean? So preconception planning for healthy behaviors and medications. Discussing potential risks of relapse and recurrence. So even when you're thinking of medication, trying to think of medications which are appropriate in pregnancy and have comparatively less risk of congenital malformation. Like last week, I had a patient who was on Depakote, a 26-year-old young lady for bipolar. So we had a long discussion and we justified her Depakote use because she had tried most of the medications which did not go well for her. And the reason I brought up that example is because I'm already thinking when a patient is in, even though she was not planning to get pregnant, but she is in that childbearing age group. And we know valproic acid can have significant congenital malformations. So having that discussion early on is more helpful. So discussing about untreated mental illness. A lot of patients have limited knowledge of that. I think their default is, let's stop the medication because I'm getting pregnant. So also discussing what are the factors if their illness is untreated. In patients with severe mental illness, decisional capacity would be also a key thing to keep in mind because you will have to talk about risks and benefits. And if somebody else is making a decision or whatever their support system is involving them in those decisions. I mentioned about medication risks and benefits and also working as a team with other services, especially the OB team and after delivery, the pediatrician. General thoughts for prescribing in pregnancy, which are standard for all, maximizing the non-pharmacological interventions. I've highlighted that in psychotic disorders, medications are usually indicated. No matter how much support they're usually recommended. Lowest effective dose, avoid polypharmacy. One study looked at how patients who stopped the medication ended up having exposure to more medications because of relapse and acute psychotic episodes when they got admitted, needed more medication at higher dose. That is higher risk than having somebody stable on lowest effective dose and in one medication. So even discussing that before pregnancy or if the patient is trying to get pregnant, so that they're not kind of tempted or encouraged to just stop medication because there is a higher risk of relapse. So avoiding polypharmacy, patient-centered care, and again, we have to document in general and medical field, but in perinatal psychiatry, I think there's more emphasis of documenting and discussing about pros and cons. So in psychotic, severe mental illness or schizophrenia or primary psychotic disorder, how do you approach patients for agitation and more so on inpatient? And the reason for adding this is this. Almost 50% of patients end up needing inpatient hospitalization. So having a plan beforehand in mind is helpful. So verbal de-escalation techniques obviously is the first step, like for any agitation patients when they are hospitalized, but more so for patients who are pregnant. Pharmacological intervention if verbal de-escalation is ineffective. And last thing is restraints. And if you are restraining a patient who's pregnant, specifically in second and third trimester, position them on the left with support under the right hip. This is to prevent any vena cava syndrome, and which can lead to less supply to the baby. So keeping that in mind would be the key if a patient needs to be restrained. Frequent monitoring for stability. I think last year or year before that, we had a pregnant patient on our inpatient unit and who would get very agitated. But the team figured out the plan for de-escalation of talking to her, checking in with her more frequently to avoid leading to that restraint stage. So keeping that, keeping emphasizing on that step, especially if a pregnant patient gets admitted, even in the ER also. So we talked about the risk factors for chronic psychotic disorders. What are the things to keep in mind? How to generally approach those patients if you're already having them in clinic? How to talk about pregnancy? What are the things to keep in mind? Having a discussion about risks and benefits. And we'll talk more details about antipsychotics in the end. So next topic I want to talk about is postpartum psychosis, which is more specific during pregnancy. So when I initially learned about postpartum psychosis, I looked up the literature. It was always a question for me: is this a mood disorder? Because in some studies, they just compare it with bipolar, or is it a primary thought disorder? So what we know about postpartum psychosis, there are multiple studies showing the association with bipolar disorder. There are patients who have this episode only limited to postpartum period, and otherwise they are high functioning. But mostly it has been associated with bipolar disorder. In my both slides for psychotic disorders, I did add delirium as well. I had on consult service when I was a fellow, I did get consulted on a patient with question about postpartum psychosis. But the patient actually was delirious. She had a reaction after she had a C-section. She had reaction to anesthesia and she needed haloperidol. I think she was given IV or IM. It's been a while. So, but that was delirium and not postpartum psychosis. So that's why I've added delirium as well, which can be acute and the symptoms can worsen very quickly. So let's talk a little bit more about postpartum psychosis. So it's a rare disorder, 1 in 1,000 or even less, some studies shows. Cause is unclear what causes it. Most episodes do occur within 2 weeks. 50% usually even earlier, within a couple of days of delivery. It is definitely a psychiatric emergency. So even if it's rare, it's worth knowing about it because consequences can be very severe. We know the trigger is the childbirth. What are the risk factors to get for postpartum psychosis? Primiparity, prior postpartum psychosis. If somebody's had it, they definitely need more monitoring in their second pregnancy. History of mania or psychosis. Some bipolar patients have been diagnosed in the past, treated, but with time they stop taking medications and most of them stop during pregnancy. So even that, there is a possibility of history of mania or psychosis. Discontinuation of medications if they have a chronic psychiatric diagnosis. Family history of postpartum psychosis is also another risk factor, and older age during pregnancy. Clinical presentation is pretty interesting. It's very diverse, the wide range of symptoms, and that's another reason that it can be missed when we're evaluating patients. So things to keep in mind for postpartum, there can be rapid change, wide range of symptoms, and symptoms can fluctuate. So initially, usually patients, they might come to you initially after the delivery for insomnia, sleep deprivation, increase in anxiety, preoccupation with the baby, more so than normal or range of normal, mood fluctuations, irritability. And those symptoms, if left untreated, can lead to more severe symptoms. I had a patient in the Northwest, I was on call in the ER, when patient actually had this almost like the stepwise. Her baby was underweight, so she got very preoccupied that she had to breastfeed and had this guilt of why the baby is underweight. So not sleeping every 2 hours to the clock, pumping and feeding the baby, that led to insomnia, leading to anxiety, leading to depression. And she was treated for those meds, but then the guilt about giving medication to her baby through her breast milk. So she stopped the medications and led to disorganization. When she was brought to the ER because she was running naked with the baby on the street, thinking that everybody wants to harm them. So it led to that. So, and this happened within 2 weeks. And this is a patient who had no history of psychiatric disorders. So even the family was traumatized to see what has happened and how to manage that. So, so symptoms can be very wide. And if somebody presents with this, checking in with those patients more frequently. There are no standard screening tools. There are no standard questions or algorithm, because this is so rare, and the presentations can be so diverse. So just being mindful and thoughtful about the steps to keep in mind will help you to make sure you evaluate patients who can develop that. So it usually does start with these mild symptoms and can lead to worse. And the biggest fear or worry about these patients is thoughts of harm to self or newborn. Differential diagnosis for postpartum. So in psychiatry or mental health, so thinking about postpartum depression, is it psychotic features related to that? Postpartum OCD, main way to kind of differentiate is psychotic disorder, more ego dystonic and poor insight, and OCD, they have insight into it. But so those are things to keep in mind when you are evaluating these patients. So there are a lot of possible medical causes: infections, autoimmune, medication-induced, Sheehan syndrome, encephalitis, metabolic. So there's so much change in women's body during that. So there's a wide range of differential, but things to keep in mind during if somebody presents with those symptoms. So diagnostic considerations, again, it's so rare, and the presentation can be so different. There's no standard screening tool. EPDS, what we do for depression and anxiety in pregnancy, cannot screen, can easily miss bipolar or psychotic disorders. So there's no standard labs you should check, but there have been studies based on that. These are some of the labs, and this is how you can think of diagnosis or evaluation of these patients. So examination, going back to the assessment, definitely checking more the past psychiatric history, asking about psychotic symptoms. Guilt I specifically added because that has been something in my few patients since I've been interested in perinatal psychiatry. Guilt has been a consistent symptom which people have reported. Even this young lady I saw recently, a few months ago in ER, it was all about guilt. My fault, the baby's not gaining weight. It's my fault. I'm not being mother who should be happy. As a result, it just declined and made things worse. It's my fault. I have to take medication to sleep. It's my fault. So a lot of guilt around during that period. So definitely asking them direct question about self-harm or harm to infant. Very important in any mental health population, but specifically in this population, asking in a very non-judgmental, but a direct inquiry. Like, we all have, it seems like this group is more already trained in this, but, mentioning patients can have chemical imbalance. And a lot of patients who have that can have thoughts of harm. Do you have or had any thoughts to harm yourself or towards harming your baby? So kind of normalizing to some extent so that they're comfortable to share. This patient was struggling by herself, very hesitant to share, even with a husband whom she was very close to. And that's what led to worsening of things, so which could have been identified early on. So being non-judgmental and being very supportive, especially during this period when women are already going through a lot. Screen for substance, examination, physical, neurological examination would be important. Labs which, some studies have kind of come up with this set of labs. Doesn't mean this is the only limited. You can always do more if it's clinically appropriate. So set of labs to think of. Imaging, usually if there is neurological indication and symptoms. So treatment, when we're thinking of postpartum psychosis, inpatient admission should come first to mind. Not always, but more chances, more likely for patients needing inpatient. Decision will depend on clinical and other psychosocial factors. Some of the examples, how severe the symptoms are. So this patient I saw in Northwest, if I had seen like a week before when she was depressed and couldn't sleep, maybe family support would have been enough. But now when I did see her, she was paranoid, running naked with the baby, thinking people are trying to harm them and running on like a busy street. That was time that she needed inpatient. So kind of seeing the clinical presentation, risk assessment, a lot of psychosocial factors make a difference. If, homeless versus good family support. So based on that, making decision of inpatient admission. Generally, my recommendation, keeping a low threshold to have them admitted. That also helps to evaluate more closely. Sometimes patients hesitate to disclose information or thoughts they've had regarding the baby or themselves. So there is a high risk of infanticide and suicide. So that's the reason I'm putting so much emphasis on this. MGH website, Women's Mental Health website, has a link where a lot of women, high functioning women with no psychiatric history, have shared their stories. So, so it's interesting to read and also kind of very, very educational from patient's perspective. Having said that, inpatient, keep a low threshold. It is hard for mother to be away from the baby. There are some states, and we don't have it in Washington state. There are some states who have this mother and baby units where they can be together, and emphasis is on bonding with the baby, breastfeeding. But we don't have that in our state. So those are preferred, and patients do better. And inpatient time is also noted to be less in those units compared to our traditional inpatient psychiatric units, where the babies cannot be there with the mothers. So another thing I want to emphasize on this, for these patients, goal is not only to decrease the psychotic symptoms for the patient, but is also goal is to support them through for mothering, how to bond, and also paying a lot of attention because this is guilt increases, a lot of discouragement increases, and feeling that I cannot be good enough mother. So a lot of these patients will need that extra support and education and encouragement. Psychopharmacology, similar slide to what I showed before. Again, I repeated it because I think these are the general factors to keep in mind during pregnancy, maximizing non-pharmacological. Again, both in severe mental illness like schizophrenia or primary psychotic disorder and in postpartum psychosis, medication is usually indicated. I would say always indicated, unless there's a very good reason not to. Lowest effective dose, avoid polypharmacy, and best way to do it is keeping them stable on the medication which works. If you keep stopping and the patient keeps stopping, there's a higher risk of more chemical exposure to the baby during pregnancy, because if they relapse, that needs to be monitored more acutely and more likely with higher doses and multiple medications. So the medication groups which have been studied for postpartum psychosis include benzodiazepines, more so in the initial stages to promote sleep, prefer short half-life, short time period. And the second medication which has been frequently studied in this, whatever the limited data we have, this medication comes up, lithium. It has shown low rate of relapse, and I'm talking about postpartum psychosis. Combined with antipsychotics or monotherapy. And sometimes if it helped a patient in one episode and they don't have bipolar history, it's also recommended to use it as a prophylaxis in the second time when they get pregnant. This is for patients who don't have any other mental health illness between these pregnancies. And last group, the antipsychotics, which I will spend more time on. Typical, atypical, and since early 2000, atypicals are prescribed way more for diverse diagnosis compared to first generation. And there are less studies, recently there are less studies in pregnancy from first generation because of low rates of prescribing this medication. So more and more studies coming up for atypicals. In general, there's an FDA warning for all antipsychotics, especially exposure in third trimester, and the complication possible. These are like withdrawal symptoms possible in the baby, including EPS, sedation, breathing, feeding difficulties, agitation, muscle tone changes, tremor. These symptoms usually resolve spontaneously or in a couple of days, but may need an additional hospitalization. This is not the reason to stop medication in third trimester for babies. This is more to be aware and educating the OB teams who are treating your patient so that they can monitor the mother and the baby. First generation antipsychotics, high potency ones there has been no consistent increased risk of major congenital malformation. And haloperidol, even though compared to before, it's less used, but it's still medication we think of. And especially with a patient who's very, with chronic mental illness, who stop medications, who's very sick and might need, and is inpatient. And my patient I had in my second year, actually, we did give her haloperidol throughout her pregnancy. And baby was fine, no malformations, and mother did well as well. There is limited data, but that data has not demonstrated effects on behavioral cognitive development. Low potency are more teratogenic. And we're talking about first generation. So there are some studies showing the rates of almost 1 in 250 patients who were treated. And the congenital malformation or teratogenic effects were significant enough in those studies. And also with first generation, to keep in mind, some patients end up needing anticholinergic medications as well, which can have its own impact and exposure to the baby. Are we doing okay with the time? Okay. Risk factors, lower mean birth weight, medication risk factors for the child baby, higher incidence of small for gestational age. Of course, the anticholinergic side effects, which can be high risk, sedation, hypotension, tachycardia, GI side effects, and of course, EPS side effects. EPS, I think you all are probably familiar with this. I don't have to spend too much time. Usually in the baby, they are transient and resolve in days if they develop due to the exposure in third trimester. But definitely from first generation, as you all know, the risk is more compared to second generation. So second generation or the atypicals, generally no consistent studies showing increased risk of major congenital malformation, no fetal cardiac malformation, except risperidone. This one study showed the high risk of cardiac malformations from risperidone. And that's the reason if patients not on it, that's not the first medication to think about if somebody needs to be on medication. But again, this was one study and there's not been follow-up studies showing similar, at least not until I checked last time, a couple of months ago. So it's not if somebody's very stable on risperidone doesn't mean that would be very clear reason to stop it. But it's also, again, in perinatal psychiatry, like any other field, talking about risks and benefits would be even more actually important, I should say, in perinatal psychiatry, with the mother and baby's father or whatever the support system who's involved in patient's treatment. Spontaneous abortion, miscarriages, it's not been shown to, studies have not shown it consistently, has not shown small or large for gestational age. EPS withdrawal symptoms, there is a risk, which I initially mentioned, the FDA warning. But again, that's not the reason to stop the treatment, but it's more of education and discussion with the patient. And the reason I keep saying that's not the reason to stop is because there is a high risk of relapse if patients stop. And when I say all this, I'm talking about patients who already have known psychiatric diagnosis, specifically psychotic disorder, primary psychotic disorder like schizophrenia. In postpartum, we'll talk a little bit more about that. So in that, most likely we don't have to worry about this congenital exposure, because the treatment would be more postpartum, not during pregnancy, in patients who have postpartum psychosis specifically. So metabolic side effects, it's interesting that limited data we have, the studies are mixed. Some studies show there is no increased risk for gestational diabetes from antipsychotics, but the other studies have shown. So to be on safer side, we know atypicals have higher risk of metabolic side effects. So keeping these in mind and working with OB, it's important to work as a team or liaison with those teams, because to educate them the need for medication and what are the risks for if the mental illness relapses or the symptoms worsen. So weight gain, gestational diabetes, dyslipidemia, large for gestational age, I think I've mentioned that before also. Psychotic disorders and bipolar disorder also increase risk for most of these, specifically metabolic side effects. So medications, second generation has more risk, as we talked, than first. In second generation, highest risk, again, probably this is not new information to you, but there is lowest risk from other medications. And when I say psychotic disorder, bipolar disorder also increase the risk. And this couple of studies have actually shown that patients specifically with severe psychotic disorder do have difficulties maintaining a healthy diet. So that probably also contributes. So again, going back to that slide of educating, if they want to get pregnant, also discussing about diet, nutrition, taking care of themselves, focusing on that with those patients or working on that with that patients. Metabolic monitoring for metabolic syndrome if patients are on antipsychotics. So which week to monitor for which, you probably all are familiar with what to monitor, but this is a nice table to think about which week to focus on or which lab work or what to monitor on those weeks. Just checking time. Medications. Again, this is not full information about all medication, and I think that's hard to do in 1 hour presentation. But the way I think of medication when patients come, I think of I have a general idea for the group, but then I think of pros and cons. That's how we all practice. Like, what are the pros and cons, and what will be appropriate for the specific patient in front of you based on those pros and cons. So risperidone, effective for psychosis, acute agitation, we know. Cons, this cardiac malformation risk, which was shown in that study. Seroquel is usually a go-to medication if patients not on any medication, and we don't know past information about what worked. It's more so in outpatient settings. So effective for mood, stabilization, depression, anxiety, psychosis. So even if the presentation is complicated, we don't know if there's psychotic symptoms from depression or bipolar or primary psychotic. So even then, it's a good indication. Sedation sometimes actually is good. And lowest placental transfer. That's why it's mostly go-to for perinatal psychiatrists if appropriate for the presentation. There is a metabolic syndrome risk and there is sedation, which can be benefit, but in some cases, I had a consultation with a patient who was a high functioning patient with bipolar, and quetiapine or Seroquel was making her too tired and she couldn't function at work. So that was a discussion to have with the patient, what to consider and the risks and benefits of changing middle of pregnancy, and what can we do during the day, or should we just do it at night if she's taking it during the day? So that discussion, so it can be benefit or limitation, the sedation component. Abilify, low risk of metabolic syndrome, but of course, akathisia risk, and less effective in chronic psychotic disorders. Olanzapine, usually in patient setting, is go-to for acute psychotic presentation and unstable patient. Metabolic syndrome, of course, highest risk comparatively, except for clozapine. Sedation, which again can be benefit or limitation in some cases. There is a case report of neurotubal defects in the baby, but again, it was a one case report, but no consistent data showing it. And that's what's about perinatal psychiatry. There can be case reports, but you have to see overall, have they been consistent, or what are the review papers, systematic review showing. Highest placental transfer for this medication. Geodon, not that much we use generally, but low risk of metabolic, and there is limited data in pregnancy. Clozapine, rarely used, but can be used, especially severe psychotic disorders in treatment resistant, but it will need very close monitoring, and especially the concern about the agranulocytosis. I get questions when, especially on consults, a lot about these newer antipsychotics, especially Latuda, for which, for some reason, people, I've had providers call and say that that's safe in pregnancy. Thing is, we don't know much about these medications. There's no human data. So usually if you're starting someone, it's better to try medication which we know more about than the new medications which we have no data, human data. Even in the animal studies, cariprazine actually did interfere in embryo development and viability of the embryo. So that would not, even if that's the only option, that's one medication to avoid more till we have more information. So antipsychotic use in breastfeeding, again, my go-to websites is Reprotox if I have to have a quick review of a medication, and also Lactamid to get more summarized information if I have a patient right in front. So haloperidol, usually well tolerated. Some things to monitor negative effects from combined with other medications. Monitor for drowsiness, perfenazine, limited data, but relative infant dose is low. Chlorpromazine, again, limited data, but the relative infant dose is low, 3%. I think 10% is what is acceptable generally. Risperidone, again, doses up to 6 milligrams produce low level in milk, limited data. Again, that's probably common theme. We have limited data in perinatal psychiatry. Quetiapine, doses up to 400 produce low levels, no adverse effects noted with studies. And you can see the percentage is very low in relative infant dose. Abilify 15 does lower serum prolactin, can affect the breastfeeding or production of milk. And then olanzapine is actually recommended first line in medication breastfeeding if somebody is not already on a good medication which works well for them. Clozapine, again, risk of agranulocytosis and limited data. I wanted to add this long-acting injections, and this is more specifically for people with chronic psychotic disorder or schizophrenia. In short, don't stop it if somebody is stable on that. Again, we have very limited data, but this was a recent review paper came up in recently last year. So preconception, discuss about informed consent, include father of the baby or whoever partner of the patient, whoever involved in the care. Consider FDA approved medications. One with longer intervals is preferred because they already overwhelmed a lot of appointments, more likely for them to show up. So prefer the longer interval ones. During pregnancy, limited data, again, continue unless there's a compelling reason not to. So in psychotic disorders, including the postpartum psychosis presentation, which is not chronic psychosis, medication is indicated because if patients are untreated and they decompensate, the consequences can be very severe. might need dose adjustments with change in pharmacokinetics. So keeping that in mind, because pregnancy physically, women's body is changing a lot. Breastfeeding, safety data limited, but reassuring. Again, not a reason to stop medication. It can increase prolactin, which might cause overproduction. In some cases, it's preferred, but overproduction can lead to mastitis. So keeping that in mind, having the OB involved on educating or working with the team, helping the patient. Avoid breastfeeding if baby preterm. That's the only thing mentioned in that review paper. If somebody has a preterm baby, and the reason would be because the kidneys and liver is not developed enough in the baby to get rid of the medication. So high possibility of high concentration of medications in the baby. And I think that's the case in most of the medications. I know we have 12 minutes, so I'm almost done. Treatment, other than psychopharmacology, all the medication treatment we talked about, of course, therapy, always default, is recommended. Psychoeducation, support self-esteem. So I'll emphasize that. It's even more important pregnancy and postpartum period. So supporting self-esteem, building confidence in mothering for the patient. ECT, there are fewer studies. I actually had a patient whom we had to try a lot of medication for her bipolar, and she did not tolerate the medication, or she did not improve. So she did get ECT and did actually pretty well during her pregnancy and postpartum. So 3% or fetal complications and 5% in pregnancy. Usually thought about these cases, like the patient I mentioned, in more of treatment-resistant cases or severe catatonic features. Again, when I repeat the slide, I want to make sure I emphasize on those points. Management of agitation, use of seclusion and restraint should be the last resort. And I think that's true for even non-pregnant patients. So verbal de-escalation techniques, pharmacological interventions. But if we are thinking of restraints patients, there are some patients who might need that. And then making sure you keep in mind in second, third trimester, position on the left side, support under the right hip to prevent vena cava syndrome, and frequent monitoring for stability. And the goal is to, of course, get them out of the restraints. Risk of, so I know we talked treatment like together for chronic psychotic disorders and postpartum psychosis. So postpartum psychosis, what's the recurrence? What happens to patients who develop psychotic symptoms first time during that postpartum period, usually soon after the delivery? What happens to those patients? So first onset postpartum psychosis, the study which came out in 2020 showed that almost 50% patients end up having a long-term psychiatric disorder, and association mostly with bipolar disorders has been noted. There are a small group of patients who have this only limited to during the postpartum period, and otherwise they are functioning and they don't need treatment. In those cases, thinking of prophylaxis when they get pregnant again is a good idea, and they don't need medication treatment throughout their life. If it's limited to that, and they do better afterwards. There is around 35% had no recurrence in postpartum or other when they're not pregnant. So first onset postpartum psychosis is not default long-term psychotic disorder or bipolar disorder, but there is a risk. So monitoring closely is recommended. And how long do we continue if somebody is postpartum psychotic only first time after pregnancy, after delivery, sorry. It's usually the risk is up to a year. So I would say continue treatment or monitoring at least up to a year. I still think if they're without symptoms for almost 6-7 months, can start decreasing the medication and monitor them closely. Prevention for postpartum psychosis. Strongest risk factor, bipolar disorder, history of postpartum psychosis. If somebody has a bipolar disorder, which when you kind of come to know when you're evaluating them, pharmacological prophylaxis during pregnancy and postpartum. So basically continue treatment during pregnancy. Do not stop if there is a risk, history of bipolar. That treatment, like non-pregnant, continue the treatment. Of course, the treatment, thinking of treatment which are appropriate during pregnancy. Psychosis is limited to only postpartum period. Pharmacological prophylaxis immediately after birth during next delivery. And thinking of medication which helped. Studies have shown lithium when it's been tried, but if there was another medication which helped them to feel better, considering that medication after delivery in that postpartum period, so immediately after birth. Emphasis on adequate sleep, family support, and definitely coordination with pediatric staff, along with the OBs. So take-home points in childbearing age group, consider discussing about contraception. I've been more mindful since I've been interested in perinatal to think about contraception, risk of untreated and treated, always discussing with patients. Schizophrenia, other psychosis, and bipolar disorders are serious medical condition, do impact pregnancy, infant, and neurodevelopment, can have bad consequences if left untreated. So stopping medication does increase the recurrence in pregnancy and postpartum. Pregnancy is not protective, okay, for these disorders. Postpartum psychosis is clearly a psychiatric emergency. It's rare, but when somebody goes through it, they can decline very quickly, like in that case. In our distant family, in our cousin family, we also lost our cousin aunt with her baby because it was left unrecognized, and she was isolating more. Nobody kind of monitored that, and people were not educated about it. So again, rare, but when it happens, it's very traumatizing, obviously, for anyone. So being aware of this, especially postpartum period, while making a decision about medication, definitely weigh risks of untreated disease as well. Not only focusing, oh, risperidone, you're doing very well, but there's a risk of cardiac toxicity. If patient has tried everything, risperidone, what worked, continue that and talk to OBGYN group and see how patient can be monitored and baby can be monitored. Medication decision based on past trials. If none, think of quetiapine and olanzapine based on the clinical presentation, if they're appropriate. Consider prophylaxis in patients with history of past postpartum psychosis. And some patients will say they don't need medication, but definitely thinking of prophylaxis, because when people go through, they again decline very fast, specifically postpartum psychosis limited to that period. These are my references, and usually good websites I like to learn more about is MGH website. They have rounds every Wednesday also, Reprotox, Lectimed. Those are my regular resources I check in. And there's also this national training, which has different kind of teaching tools also, which I use. Again, I'm not affiliated with any of them, but I thought I'll share the resources because this field is changing so much. It's constant reading and up to date is needed. That's it. I was hoping to get more time, and I apologize for having just a few minutes. Thank you.
Thanks. I had a quick question. So with the babies who are born prematurely and the recommendation to not breastfeed due to their underdeveloped organ systems, is there any recommendations for supporting mothers for pumping early on to establish a milk supply if later on breastfeeding is something they want to do?
Kristen, that's a great question. I think it's not only not recommending, telling them not to breastfeed, depends on what medication they are and what is the infant dose which is going to be for the baby. If they are very premature then and patient needs medication, then I would discuss with mother to discourage. I don't know if the data, especially for antipsychotics, that pumping early on, if that has any better kind of a result. That I'll have to look up, but that's a great question.
Yeah, and I was more kind of thinking about like if they are discouraged from breastfeeding, then they wouldn't be able to build their supply. Basically, they wouldn't be able to breastfeed later on.
Oh, you mean just pumping and dumping kind of?
Yeah. Is there any like recommendation to tell the patient, you know, if you want to breastfeed later on, now you should pump and dump to build your supply, that type of thing?
That's a good question. I don't know the answer to that question, but I would love to look it up. But that does make sense, because if you don't pump, the breast milk production will decrease for sure. I don't know standard, but that does clinically make sense to me. But that's something I will definitely look up and get back to you on that. I'm going to just take notes of things. Great question, Kristen. I don't know of any standard recommendation, but does definitely make sense to encourage mothers to do that. And again, keeping in mind, some of them will have very limited functioning. So if they are able to do it and not get overly focused on doing it every 2 hours at night, because sometimes I think that can be a message from, like, suppose lactation consultant or OB, people who are non-psychiatric field, emphasizing that on the mother. Like that patient I saw in ER recently, who was all focused about baby's not gaining weight and she has to breastfeed every 2 hours, did not want to take sedating medication because she said she would sleep and not lose all the milk supply. So I think keeping that in mind is also important, and encouraging them definitely to sleep overnight. But I think I will definitely look it up and let you know if I find any literature on that. Very quiet audience. So either everybody's learned everything, no questions, or or I've been talking too long.
Well, thank you so much for joining us today. It was a great presentation. I know I learned quite a few things, and I'm sure the team did too. So thank you so much for coming.
Thank you for inviting me. Take good care. Bye-bye.
Bye.